Within your clinical practice, how have you helped promote early adoption of therapeutic support surfaces? And we'll fire this one to Julie, please.
Well, early adoption was probably the focus of my presentation. What I'd advise is engaging with and highlighting with the key stakeholders at an early opportunity. So raising the profile of your request, if you like, developing a business case or a business proposal, or even just an idea. It's a first draft. We're sharing that with influential people, shall we say. So people, often people who hold the purse strings, they're very influential. Patients, staff who are looking after the patients. We often use, I'm sure Lorraine and Debbie do as well, well, they have done, patient examples. Nothing's more powerful than describing a patient's, just one patient's poor experience speaks volumes, particularly if there's some images that go with that. So we often, and the horrified, you know, you're going to show some awful pictures, but it's happened, some patients do develop pressure damage. Get consent to use those images and share them with members of your organisation who may not otherwise know some patients' experiences and what happens. And that patient experience, along with financial benefits and quality of life benefits, builds up to be a really strong case.
We've been asked, what are the top 3 pieces of advice that you can give to support prevention of both skin damage and deconditioning of the patient without compromising on the other?
That's a really good question, and it's actually quite a challenge very often. I suppose that preventing deterioration whilst promoting mobility is about thinking about the surfaces that you're using really carefully. One of the things that can prevent you rehab is that you're not appropriately got appropriate analgesia on board, so making sure any pain is managed. Also thinking about whether the patient what the balance is for the patient who's mobilizing from a surface, what the surface they need is, and whether that will impede their ability to mobilize, thinking about whether the surface has adjustment capabilities, for instance, to a static mode, while you're trying to promote that. And the biggest risk for getting a pressure ulcer is not mobilizing, is not moving. So whether your patient is dependent on you for moving or can move themselves, keeping people mobile is the biggest thing that you can do to prevent pressure ulcers. And that includes in the chair. So I'm just going to add that little thing, which is thinking about, once we put people into a chair, that actually the forces that are going through them are quite different, and therefore encouraging mobilization while you're in the chair, even if it's how you lean forward and back or getting up for a walk after an hour, can be really important.
That's wonderful. Thank you very much, Deborah.
Thank you. So another question, as a social worker and not carrying out personal care, are there any other telltale signs of a person suffering from skin breakdown? And we'll give this one to Lorraine, please.
That's an interesting one. If it's in the community setting, the social workers may be going in to see the patient as part of getting care packages sorted out. And I think it's about reading what's going on with the patient. They might be giving clues that are not necessarily verbal clues. It could be they're starting to get fidgety, agitated, shuffling around. They may then start to verbalise that they feel a bit uncomfortable. They may be having numbness in an area, which could be a sign of pressure damage starting. It could be something completely obvious, like there's an odour, a smell, wetness, dampness on the clothing or the bedding. They may be a little bit confused if they've got damage that hasn't been picked up, and hopefully you would think that it had. But if it's a social worker going in for an initial assessment because they've been asked to help, the family aren't coping, they may pick up some of those clues where the patient is a little confused, maybe a little bit clammy. a little bit incoherent, maybe uncomfortable or unwilling to get into certain positions because it's uncomfortable and it hurts them. So I think if they pick up on signs like that, then it's about addressing it, perhaps speaking to the district nurses or involving the district nurses, because they may not have had that input before.
So we've got a question: what is the best practice to keep comatose patients' skin intact when they're attached to mechanical ventilation and there is no help to rotate patients?
So is the focus on the ventilated patient or the fact that there's no, did you say that there's no one to help reposition the patient?
There's no help to rotate, whether they mean mechanical rotation, there's nothing that elaborates on that. Just also, I guess, keeping patients' skin intact when they're on mechanical ventilation.
Yeah, so, well, critical care staff are very experienced in managing vented patients. So they're very, very experienced in managing the ET tube. We find in critical care, particularly for larger patients, where more staff are needed to help manually change their position. And there sometimes isn't that number of staff available at the same time. We tend to use a turn-care assist mattress, which is absolutely fine for a ventilated patient, because you kind of change the settings at the foot of the bed. So one staff can manage the tube, if it even needs managing, and the mattress will automatically inflate on one side to position the patient, and then that can be set a pattern, or it can be manually done. So, and the safe feature of being able to use a turn-care assist to rotate yourself, take control of it yourself, rather than something that has set times every 2 hours or whatever, is that you can have a focus on the tube at the time that you're changing the position of the patient. But the mattress does the work for you. That's the point. So the mattress inflates on one side and repositions the patient. So we often use something like a turn-care assist mattress on our bariatric patients for exactly those reasons: the ventilation and the difficulty to manually reposition. I hope that's what whoever posed the question meant.
The question is that trolley waits at A&E are quite common. What advice can you give to help prevent skin friction and pressure while patients are having long waits?
I think it's understanding a couple of things, really. One is about trolleys, what type of A&E trolley they've got. Ideally, if you've got something that has an auto contour function, that is a big benefit because it's going to keep the patient more in shape. And if I put my head back to my very old manual handling days, if you've just got a manual backrest elevation, I would always say put your trolley with a slight head down tilt first before you bring your backrest up, so that you're not actually allowing the patient to scoot down the trolley surface, because you often see them, if they don't, you see those patients go around an ED department and they've got a little old lady and her head's on the lower part of the backrest and her feet are hanging off the end because they've not thought about the repositioning, and it's making more work for themselves. And I think it is that understanding, looking at what is in front of you, what can you achieve. If you're fortunate and you can get the patients onto a bed, then we try and get our patients after a certain amount of time onto the bed within the ED department before they get to the ward. But that's the logistics that we try and strive for in our department, rather than keep. But then again, my average age of patient is 81 that I'm dealing with day in, day out. So I think that does play a part on it. But really do look at your trolley. If you've got an auto contour, use that function. Don't just try and bring backrest up first.
Brilliant, thank you. And the question is whether or not mattresses are available for the community, and yes, just whether or not they're available kind of community-wide as well as acute.
I do know of patients that use them in the community, and I have a lady that started off with significant category 4 damage that came into us with MS and had to have debridement, negative pressure therapy, and was a fairly young lady, wanted to get home to her family. and we actually negotiated with the commissioning group and the CHC, and it was actually funded. And I think she's now in her third, going on fourth year of being on Dolphin in the community. That's actually been funded by Continuing Healthcare. But that did take 6 months of the trust paying for it in the community whilst we've battled that out. And a bit like both Debbie and Julie have alluded to, you have to look at the finance. It was actually more cost efficient for her to be sent home to her family, to do what she wanted to do, to be kept safe with a wound that was progressing nicely and healing well, than occupy an acute bed. So that's how we did it. But yes, it is equipment that you can, but that's down to providers.
Brilliant, thank you.
Thank you. And a similar question really that's been requested for Debbie. How did you decide to use this therapy? And again, how did you overcome the management element to ensure funding was provided?
So I think, and I've reflected a lot as I'm listening to everybody today, that I'm going to be even more proactive moving forward. I mean, this particular case, I tried the standard things that we would try and wasn't seeing the outcomes I wanted for the patient. And it was a sort of night of the long souls, where you're sitting thinking, what else can I do? What am I missing? When I remembered that I'd seen this some time ago at a conference. Moving forward, we are now much more proactive in that use. And I think everybody has said similarly, there is a really clear financial case for the proactive use of this type of equipment in terms of not just what pressure ulcers cost trusts and cost people in terms of their lives, but they have an organisational impact as well in terms of organisational reputation. So that's another thing that I've used. And I think very much like Julie was saying, I remember some work I did some time ago, somebody coming to me after I presented and saying, what I'm taking away from what you've said is that patient stories work, and bringing people's focus back to the person who is at the centre of this need can be really powerful in making the case that you need to make.